Hello, welcome to the short where we're talking congestive heart failure and albuterol. Can you give that CHF patient albuterol? Let's talk about it. So on the board here, I got crude depictions of alveoli, lungs, and bronchioles. Alveoli is going to be at the very base of these bronchioles, and that's where gas exchange is going to take place. That's where carbon dioxide from our body is exchanged for oxygen from the environment that we inhale. Works its way all the way down there, and these tiny little capillaries are going to enable gas exchange to take place. In congestive heart failure, I have fluid backing up into those alveolar space, taking up precious real estate where gas exchange takes place, meaning that there's less room for oxygen and carbon dioxide to be exchanged so that I have less available oxygen being delivered to the precious tissues of my body. So, what happens when I have albuterol on board? Albuterol is going to cause bronchial dilation. It's going to cause smooth muscles in the bronchioles, the bronchus, to dilate, to get bigger, to expand, creating more real estate for air to move through. These are typically used when you hear wheezing, when I have constriction of that smooth muscle, and that creates a wheeze, a wheeze, a wheeze. You can make fun of me or whatever, but I'm trying to get the point across. It sounds audible, and you can hear it, and it's very telltale. Sometimes people say in congestive heart failure, you can hear that. You can hear a wheeze. Well, what are we hearing? Now, you're going to hear two types of wheezes. You could be hearing true bronchial constriction. You know, a lot of the times that we have a patient with congestive heart failure, they have comorbidities, things that exist alongside other health problems or in conjunction with them. And so these patients could very well likely have both COPD and congestive heart failure, and they both could be going on at the same time. So if you got that CHF patient and you hear a wheeze, it could be true bronchial constriction or what they call a cardiac wheeze. What's going on with that cardiac wheeze? So I'm going to zoom in here a little bit. I don't even know if you can see it that well. So we have bronchial space here, and we have fluid that has filled up the alveoli, and it is making its way along the lining of our bronchioles, creating less real estate. So our bronchioles are typically a certain size, but when I have fluid lining the inside of them, that creates less real estate for air to move. Air that carries precious oxygen that we need to work its way down to our alveolar bases so that gas exchange can take place. So if we are giving a bronchodilator when someone is actually experiencing the cardiac wheeze, then what's going to happen there? Well, if I have smooth muscle tissue that is not constricted because I'm not experiencing a bronchospasm, well, bronchodilation isn't going to do very much for it, is it? So can you give albuterol to these patients? You can. Is it going to help? No, it's not going to help your congestive heart failure patient who is only experiencing congestive heart failure. This is because there is not a smooth muscle constriction. There's not a issue there. You know, so if I have dilation, it's not going to do much. All right. Now, what will happen though is if I continue to treat that patient with beta-2 agonists like albuterol, well, my congestive heart failure, that it's already to the point where it's lining the bronchioles, it's going to get worse. So it's not that the albuterol is making your problem worse, it's that your failure to address the root cause of the issue is making the problem worse. So what do I advise you to do? Well, reassess your patient continually. Like I said before, you could have a patient that has both of those things going on. They could have their rales and they could have their wheezing combining, or crackles or whatever you want to call them, fluid in the lungs existing alongside wheezing, combine this will likely sound like a different sound that is more obscure. I like to compare it to a garbage disposal or something that sounds incredibly junky and disgusting. It's nothing that they taught you in paramedic school. You get out there and you're like, what the heck is this? I haven't heard of this. Most likely it's more than one lung sound compounding into something different. And so it's difficult to differentiate those two things. So, getting off my train here, what do you do? How do you differentiate that patient from a cardiac wheeze for a true bronchospasm amidst CHF? Continually reassess your patient. Say you have that ambiguous lung sound, or you just straight up hear wheezing with your patient with congestive heart failure. Throw that DuoNeb at them alongside CPAP, and then continually reassess. Is this making my problem better? Is this making my problem worse? Are my signs and symptoms, is my patient presentation, skin color condition, are my vital signs, what do those look like? And if your patient is trending downwards, I need you to reevaluate what your choices are for treating them and potentially pivot to a more aggressive congestive heart failure treatment modality, whether that be nitro use alongside CPAP, maybe that's increasing your pressure, maybe they need more coaching. You know, I wanted to address this issue because I've continually heard paramedics say, you cannot treat a congestive heart failure patient or someone who has CHF with albuterol, and that's not necessarily true or accurate. I think we need to think critically about what we're doing, why we're doing it, and we need to continually reassess our patients. Hopefully you learned something in this video, and if you got any more ideas, let me know. Thank you.